here for this. So, and I also am grateful to ISNAF, to the Italian Scholars, Scientists and Scholarship, Scholars of North America Foundation, to assist Italian scholars, physicians, scientists, and to work in this country. We're happy, we're proud, and we are extremely grateful to be able to provide our service and our career, to develop our career here. Well, I think everybody knows about COVID. We know, it seems that we never know enough, but we know a lot. We count the number of people that every day die. We know in Chicago, Cook County is the county with the highest number of positive cases in the United States. Fortunately, not the deaths. We're not top in the list of people who are dying, but the number of positive cases it keeps going up. So it's an issue, that it's a crisis that we are still living. All of us in our hospitals, in our communities, are still very much affected by COVID. What we know about COVID is that it has changed, I mean, everybody knows, has changed everything. Has changed our lifestyle. But as health providers, it has changed all of a sudden, in a couple of weeks' time, has completely changed the hospital, has changed the way we receive patients, we talk to patients, we see patients. So COVID has meant, from an institutional standpoint, every hospital probably in the country has decided to double or triple or even more increase the number of beds in the hospital for COVID patients, which means, though, that has decreased the number of beds for everybody else. The intensive care units, which are area that hopefully not many patients get admitted on a regular basis, have become all of a sudden places with 20, 40, 50, 100 patients depending on the hospitals. And these are people who require a lot of care, and a fraction of these patients unfortunately die after some time. So all the resources of the hospital have been immediately deployed to support an emergency like COVID. We, of course, are all favorable to this. We have all immediately, as healthcare providers, nurses, physicians, volunteered and have been ready to do whatever was necessary. I think the reason why it's important that tonight we discuss a different topic is because in this time, many people who were not affected by COVID, unfortunately, were sick and are sick. And COVID did not replace other diseases. So the problem how to take care of patients who need healthcare assistance, who need to be admitted to the hospital, to be seen in the clinic, to receive treatments, chronic treatments or acute treatments, could be surgical or medical. These people actually suffered because somebody had a heart attack, may not have found the place, the room in the hospital because there were already too many patients with COVID. Other patients who needed surgery were delayed. Patients with chronic diseases, like people on dialysis, were kind of, we needed to have a different strategy. And so we had to adapt what we did before to a new normal. Everybody's talking about new normal. New normal means for us, for example, whenever it's possible, telemedicine, but also means to be able to continue to take care of these patients despite COVID. So this is the platform for tonight, to have colleagues with me to address some of these issues, giving some details and some concerns, but also some answers to how we do this, how we want to take care of every single patient, regardless of COVID, and in how this is possible. So the first speaker for tonight will be Professor Benedetti. he's the head of surgery at the University of Illinois in Chicago. So he's in charge of all the surgeons in the hospitals. And I asked him to comment and to discuss what happened with surgery during the COVID crisis and how patients were treated and how he sees the next phase. Thank you.
Damiano, thank you for the introduction and good evening to everybody. As you all know, the 9th of March, our governor issued a disaster declaration that had immediate consequence in the hospital. In particular, all the hospitals were to be prepared to a surge of case of COVID positive patient that, as Damiano described, has pretty much changed completely the outlook in our hospital. Most hospitals have a COVID area and non-COVID area. And at the beginning, the COVID area was the largest one. There was limitation on how many patients you could admit and how many patients you could let in the ICU. Everything was geared to avoid that the system would not be overwhelmed by the surge of COVID cases, like happened in New York. Thank God in Chicago, although we had a lot of cases, we did not get overwhelmed. We always been able to handle our volume. That is substantial, between 60 to 90 COVID positive patients in our hospital, with 50 of them to 60 in the intensive care unit. Of course, surgery was immediately impacted by the new situation. Think about the fact that anytime we do surgery, in a percent of case, we need inpatient bed, we need ICU, we need a ventilator, we need all sorts of stuff that was actually needed for the COVID positive patient. So as a consequence, like in many hospitals, and I would say what I'm describing for my hospital has been done universally in all the main hospitals of the city. We start by shutting down all the elective surgery, the hernia, the gallbladder, the plastic surgery. That was immediately eliminated. We eliminated our clinic and switched, as Damiano said, to telemedicine. The reason why surgery must shut down is because we are, of course, high-intense specialty using a lot of hospital resources. Of course, we generate a lot of finance for the hospital. In fact, in our hospital, like in many, 50 to 55% of revenue comes from surgery. So as you can see, immediately we put our hospital in a financial problem. They're losing between 15 to 20 million a month. The only people that are winning are the insurance company. They don't pay for surgery anymore, and they still receive the full of the money coming from insurer. So what's happened is also, we learn from New York and from Italy. In New York, where the wave was as bad as in Lombardia, most of the OR were actually transformed into ICU room. For example, my hospital has 22 rooms that could become, if needed, the individual room for patients with COVID. My friend at Columbia Hospital, at Columbia University in New York, at the Methodist Hospital, told me that during the peak of the pandemics, all the operating rooms were transformed into ICU room, except for 3 that they left open for emergency. The situation was that bad. Of course, we did not shut down completely the surgical activities. We did protect some area. For example, all the emergency we continue to do. We continue to do cancer surgery. I don't think it's fair to that cancer patient to wait. And we continue to do transplant cases, in particular cadaver transplant. Living donor, we did pause for about a month and a half. The reason to keep cadaver transplant going is because those are sick patients with high mortality on the waiting list, and they may have one in a life opportunity to use a particular donor. I want to stress that even in North Italy, in Veneto, Lombardia, where the epidemics was terrible, the Italian government never shut down transplant. In fact, I used a document from the Italian Ministry of Health to convince my hospital to continue transplant, in which they were stating clearly that even in the worst of circumstances, Milano, Bergamo, Padova, they would actually allow the transplant program to continue for cadaver cases. So we did, and we did a good number, because many programs were sort of prudent in accepting donor. The American College of Surgeons ranked the most important case to kept open, And the case that I mentioned, emergency, cancer, and the transplant from cadaver donor were ranked on the top tier. Of course, we stopped completely doing simple case, elective case, and so forth. And some of these patients had what we define time-sensitive surgery. People in pain, people that had disability, craniofacial center couldn't operate it, children that need important procedures for their well-being. So it was painful, and a lot of people suffer from it. As Damiano said, we submitted to the overwhelming necessity to face this onslaught of the coronavirus. And I think that Illinois has done quite well. Clearly, there's still about 1,000 to 3,000 cases new per day, but this is a result of expanded testing, and we have seen, at least in our hospital, a decrease of the acuity, meaning we are not overwhelmed by all these very sick patients at the beginning. And the governor, that I believe did a fantastic job, has invited the hospital to resume time-sensitive surgery from May 9th, which we did. So from May 9th, we restart doing elective cases that are more urgent. I'm talking about craniotomy for aneurysm, I mean, big stuff. And in fact, we have already pretty much taken care of all the time-sensitive case, and we are doing a lot of outpatient now, because of course, outpatient surgery does not tax the hospital in any way. It doesn't compete for ICU bed, it doesn't compete for hospital bed, it doesn't compete in a word for hospital resources. But we need to still follow the guidelines set forward by the governor that we need to be ready any day to a surge of the COVID cases. So we are keeping the hospital always with 20% of ICU bed available. Should all of a sudden we would be overwhelmed by a new onset of a severe case of the COVID. So altogether, I think Illinois can be proud of the way both the government and the hospital have handled the crisis. I did not have any impression that we could not take care for really urgent cases. We always had access to the OR. And now, in the last 2 days, we are up to 60% of our capacity. And of course, the plan is not only to go to full capacity in the next few weeks. We have a catch-up to be made. In my department alone, that include most of the surgical specialty, we have 1,200 of cases that we cancel. So we not only go to 100%, but probably by mid-June, we will start operating on Saturday at night until we have done with backlog and hopefully resume normal activity in a couple of months. But we owe to our patient to take care not only of the urgent one, but also those that need simpler operation. For example, shouldn't we take care of a cataract or a knee surgery or hip replacement? That would be low priority in the grand scheme of things. But if you don't, you have people suffering at home. So I provide the general outline, and I would like to be conscious of the time and maybe let Dr. Rondelli introduce the next speaker. I'll be happy to answer any question on the matter.
Thank you very much. Thank you very much, Enrico. And I think that's a great introduction of surgery. And there will be, for certain questions, I already have a couple that I'll probably wait for after everybody has spoken. So the next aspect of the non-COVID patients, which is a large, actually, it's been probably the largest change, and the biggest change has been everybody all of a sudden learned about telemedicine. We always heard of it, but many of us never really had to deal with it. And immediately we all became part of this new address. So telemedicine basically means to talk to a patient who's not in front of you, and they can be reached in different ways. The question of telemedicine, and that I think Professor Kocjancic will discuss this, is what are the pros and cons of telemedicine, and what are the infrastructure that is necessary, and what type of best care can be provided with telemedicine as opposed to not so much. So, Professor Kocjancic, Ervin.
Thank you, Damiano, and dear friends and colleagues. It's a very peculiar time of our life that we are living with this pandemic. And the way that medicine is practiced and is going to be practiced is changed for good because of this event. There, in the acuity of the events, you have two ways of practicing medicine, like Milano, Bergamo, New York way, where you just forget your specialty. You are the physician who is in charge of the emergency. So it doesn't matter if you're a specialist. You can be the best specialist in any area. You have to provide the acuity, the tons of sick patients that are invading the hospital. Or you have the way, like we were lucky because of the good government, and I agree with what Enrico just said, that we, despite having that high number of patients, we didn't see this surge of hyperacute patients coming to the hospital and blocking the regular activities. So I'm a urologist, and in a urology, besides dividing ourselves in two groups, so when one group was practicing for a week and the other group was at home, so to avoid to have the whole group getting exposed and eventually getting sick with the COVID infection. So we have like a back plan for this. We also decided to divide our patients. So, and the question that we ask ourselves is what we have to do, what we have to provide right now to the patient, what can we do for them, and what can wait, what can we be delayed. So for instance, as said, oncology patients, surgery for cancer cannot wait, because you can survive COVID and then a few months later you die of an advanced testicular cancer. It's not, you're not doing a good job for the patients. But more elective cases like enlarged prostate that still causes a lot of problems for the individuals, this can be postponed, and we can wait for this to advance. But there's a lot of things, especially urology is a nice mix of surgery and clinic activity that where you can still take care of these patients. So the worst thing is for the patient is to have the feeling that they are completely abandoned because of the other events. And there's many ways how you can keep taking care of your patients. Of course, at the beginning, we limited the access to the clinic, which is still reduced. It's a little bit eased now, but it's still scrutinized. We are still selecting which patients it's safe to bring to the clinic and which patient can wait. And the best way to keep offering medical service for these patients in their houses is using telemedicine. So telemedicine is not a really new thing. Has been used a lot in developing countries, especially when you need the consultation with top experts. The reason why here was not that widely popular is related with reimbursement. Until the COVID, there were many restrictions that were applied to reimbursement of this medicine. So that's why it was not that spread. One of the advantages of COVID in this term, I think it's something good that's brought this horrible pandemic, is that now we are having this ability to offer the use of telemedicine and the new technologies in our patients. So this is safety for us and safety also for the patients. Use of new technology and aging, it's very oftenly misinterpreted. And I remember, this is like a personal experience with my brother. I have a twin brother, and we have an 80 years old mom. And I gave her for her 80th birthday an iPhone, and my brother said, "You're out of your mind. She's not going to be able to use it." And I have to say, she is not only able to use it, she's actually overusing it with being able to text, to see, to call, to video call everyone. So it's possible. It's actually, as a matter of fact, there are studies showing that in patients population over 70 and 80, in cardiology settings, actually the use of this type of ability to use smartphones was safe and was very well accepted by the patients. Now we have witnesses an increase in the platforms that allow in a safe way to talk with the patients. You have to, it's not enough to just have like a video call, because this can be bumped. You can have HIPAA compliant in this. So, but we have quite a few of these now that are available in our practice. What can we do with these video calls? We can, first of all, do the first assessment of the patient. You can do the follow-up consultation. For instance, if you have to review the imaging that you require, the lab test that you require, you can do this. You don't have to have the patient come back to your office, wait there in the waiting area, and so that you can discuss this. And I think this is one of the things that I really think I'm going to keep doing also when the pandemic is going to be over. But there are things that cannot be done as of now. For instance, do a physical exam. There are a lot of sketches on the social media, for instance, showing how a gynecologist can do a virtual exam, and I just leave you to the imagination on what the proposals are. So there are things that we have to have the patients coming to our clinic so that we can do the physical exam. But again, here the technology is also advancing significantly. For instance, there are tests that we are doing in urology, where we are measuring, for instance, the speeds of your urination. Gives us a lot of information on the prostate health and the bladder situation. These tests usually consist in you urinating, you're peeing in a machine, and then we obtain a graph. Now you can do the exact same test using a phone. There's software that actually can recognize the audio tracing of your flow and convert this into your flow. There are other devices that we can use that can be available, like a wearable ultrasound probes that you can put into they're actually underwear designed for this, and they can track, for instance, the empty of your bladder. There are patients, I do a lot of neurourology, so there are patients that needs to be treated. This is potentially a little condition if you don't address their proper bladder emptying, because it can affect the kidney function. And so it's very important for these patients to be sure that the bladder is empty. Now we have the technology this is not just in the labs. This is actually sold and can be used to the patient can wear and gives us this type of information. Another thing that we are typically seeing with the new technology is that there is a phase of extreme enthusiasm. So everybody is jumping to use. So everybody say, I'm going to only do telemedicine from now on. Then there is a phase of reality when you recognize that maybe it's not as good as we thought at the beginning. And then it comes the phase of a reality. So you keep the good portion of this telemedicine. And I think there's a lot of things coming up in the pipelines of research labs that are going to allow us to have a remote contact with the patient and use this in our clinical management. The last word I want to spend is also on within the department. So among us that are dealing with the health, that are working on patients in a very extreme situation, I think it's important also to think about our wellness, our mental wellness as well. That's why we, for instance, our university and the hospital provide a hotline that supports the health workers, but also within us, within our department, we have like these virtual happy hours where you can just release, you relax, you share your frustration, and then you can offer a better job and a better care for the patients. So thank you, and happy to answer any question.
Thank you, Ervin. this very important aspect of telemedicine, and I look forward to questions that I'm sure that they might be related to this. The next speaker is Professor Gallon, and Lorenzo Gallon is a nephrologist at Northwestern. He's also a transplant nephrologist. He's a teacher of the director of the fellowship program there. And I asked Dr. Gallon to describe how is in this time is we can address and we can take care of patients with chronic diseases like patients on dialysis or on renal failure that do require a frequent hospital care, or can be home care, but could also be clinic care. So Lorenzo, please. Thank you.
Thank you so much, Damiano, Dr. Rondelli. Thank you also to the Istituto Italiano di Chicago for creating this scientific meeting. So as Dr. Rondelli explained, I'm a nephrologist. So the population that I take care of are patient with kidney disease, patient on dialysis, patient with kidney transplant, or patient that come to the hospital because they develop a sudden kidney disease. So the first things I would like to explain is how this disease has impacted the population that I take care of it. Number one, the patient on dialysis. So in this country, we have probably around 500,000 patients on dialysis. And typically, these patients have a lot of comorbidities, such as diabetes, hypertension. And because the proximity of the dialysis between patients, the virus actually spread quite rapidly in the dialysis unit at the beginning. There have been reports every day of COVID-positive dialysis patients. Right now, we know that there's about 6,200 patients that actually reported COVID-positive in the country. And unfortunately, the mortality of these patients is quite high. For the reason is mainly because they carry many comorbidity, many diseases, but also because of dialysis per se put the patients at risk for infections. The mortality in patient on dialysis has been reported around 13% when the dialysis, when the mortality in the general population is about 2 to 3%, so much higher. In the transplant patients, are patients that are they take chronic anti-rejection therapy to maintain the function of their kidneys. They also, the infection has created a significant amount of problem. For example, the mortality in these populations, especially in the area in New York, where the pandemic hit very hard, was being reported in two separate studies recently published in important journal that we typically New England Journal of Medicine and others, about 28%, the mortality of 28% from Montefiore and from the Columbia University around 18%, much higher than the general population, most likely because these patients, because they take chronic anti-rejection therapy, immunosuppressions, they are unable to mount an appropriate response against the virus. But then the other population that we are seeing right now, this is something new. We don't know too much about this virus, as Dr. Rondelli before said, is the fact that this virus seems to have a tropism against the kidney. So it actually does travel from the lungs where it gets, it goes directly to the kidney, cause damage into the kidney to specific cells important for the function of the kidney, called the podocytes. And we actually had many patients in the hospital that developed significant kidney disease from this virus, and they had to be, at the moment, observed. Unfortunately, we don't have appropriate therapy. Another thing I would like to mention about the patients that I take care of, that even though this being said that the majority of the problem in New York and for us was the lack of ventilation machine, mechanical ventilations. In New York, one of the crises that they face, and actually we almost faced the same crisis here in Chicago, is the lack of dialysis machine to be used to care for the patients with that were infected with COVID. Patient transplant patient, also patient that came to the hospital, regular patient, COVID positive, developed significant renal disease that require dialysis machine. And we didn't have enough of this machine available to actually take care of those patients. There was a lot of work behind the scene to be able to retrieve machine or do dialysis in a short period of time, so we have more machine available for our patients. Now, these are the COVID positive. So how this actually has affected the population of patients that they are not COVID positive, but they are still our patient. The patient on dialysis is not COVID positive. Patients that they're waiting for a kidney transplant. So as Dr. Benedetti before said, one of the things that happened right away that patients that were on our transplant list almost refused to be transplanted because they were afraid of getting infected with COVID. We had in the past 2 months almost 12 patients that refused to be transplanted because they were afraid to be infected. Many of our patients didn't go to the hospital. You know, when I was talking to one of my colleagues of the emergency department, they told us that patients with chest pain, you know, basically would drop significantly. So the amount of patients with chest pain going to the ED, to the emergency department to be treated, drop. So the same things that happened to our transplant patients. They didn't want to come to the hospital to be treated. Another thing that this infection has affected our patient population, that this is the transplant patient in this particular case, besides transforming our care to telemedicine, which has some of the limitation, but allows us to communicate with our patients, at least to understand if they're doing well, is that the frequency of the labs, the frequency of the amount of laboratory tests that we typically do for our patient had to drop drastically, mainly because the risk for this patient to go to the laboratory and be checked. So for example, typically transplant patient get checked once a month or even more frequently. We had to scale down the frequency for the obvious reason to maybe once every 2 months or every 3 months. So we scaled down the laboratory value, which is essential for us to monitor the function of our kidney. Another thing that happened to our transplant program is that we dropped completely the number of living donor kidney transplant. And again, like I said before, even the number of cadaveric kidney was forced to drop for decision of our institutions, because we were trying to be obviously to apply the proper safety to our transplant to our patients. Another important issue that I think will probably coming up and phase the population that I take care of is the availability to have medication for them in case they become COVID positive. For example, the antiviral regimen that have been used today, that have been tested today, they cannot be used for patients that have kidney dysfunction. So if you have a kidney dysfunction, you cannot take remdesivir, for example, one of the medications that is being tested right now to see the efficacy. So that is a big problem, because we talk about very vulnerable populations that with a very high mortality, that unfortunately we cannot test these medications because they get tested typically in patients without kidney disease. And furthermore, down the line, down the future, I believe that when vaccine will be available to our patients, as you know, vaccine now are being tested in very, very rapid fashion. There's almost 150 laboratory and pharma around the world testing for vaccine. But all these vaccines are indeed vaccines that are not constructed the same way as the past. The new vaccine, we don't even know how we're going to respond. But one problem that we might face in this face in the future in this vulnerable population of patient on dialysis, a patient with kidney transplant that typically don't respond quite well to typical vaccine, is how we're going to be able to vaccinate them, to protect them when the lockdown is open, they have to go back to their own life. So that is another big problem that we need to face and try to understand how to generate a proper vaccine for this population that is really vulnerable for the infections. So I'll stop right here, and I'm going to give the word back to Dr. Rondelli. If there's any question, we'll be happy to reply.
Thank you, Lorenzo. I think you raised several important points that will be interesting to develop a little bit further if we have time, and I'm sure that people may want to ask about. Just to finish this first part of the evening is I'll discuss some issues that related to another patient population, which is the patients with cancer. Cancer, of course, is a word that means many different diseases. Some of them are emergencies. Some other can be watched. Some others can be delayed. But as soon as a new diagnosis of cancer is made, no matter how in some way benign is the prognosis, there's an immediate panic, an immediate fear that is generated in the patient, in the family of the patient. So you can imagine being diagnosed with cancer at the time of a pandemia. That creates a lot of course, stress. So people want to know as soon as possible how to see a doctor, what is going to happen. So the first thing we decided when the pandemic started, we did not obviously close anything in our hospital. The oncology part, the cancer cannot wait. We did decrease the number of physicians in the clinic, as Dr. Kocjancic said before. The first concern was to keep someone on the bench in case another doctor was falling sick, and whenever someone is not feeling well right now has to be quarantined for at least 2 weeks out of the hospital. So we have to keep always somebody ready to step in case the one in front of the line was down. So we decreased the volume, but the patients were all seen. And we decreased our volume in the clinic about 50% of the visits initially, but we did not decrease the number of patients getting chemotherapy. The infusion area where patients can receive IV chemotherapy or any kind of chemotherapy, we could not decrease it because the need is now. That what meant was to discuss with the patients options that could be, yes, we can delay a week or two, or we have to do something now and then plan for the next phase, maybe surgery afterwards, maybe radiation therapy afterwards, whenever was possible. That created a dialogue with the patients who are in need to have answers as soon as possible, but also are very scared. People are afraid to come to the hospitals to get infected with COVID. On the other hand, they want to be, when they need to come to the hospital, they want to be reassured that they will be safe. One aspect that I have not heard from my colleagues that I think it's important to mention is that in all these operations that we have developed, all these procedures, a factor was our staff. Our nursing staff was always there, was never left home, and they've been the one actually at higher risk of being infected. And in fact, we did have a number of nurses who tested positive because of exposure to COVID patients. We have also, unfortunately, in our hospital, a few nurses who passed away. But this is an important thing, that this is not stopped. The care of these patients, of acute patients, of cancer patients, cannot stop. And so we decided that inpatient, the ward in the hospital has been as full as always, even more during this time, with patients that are not COVID patients, but need to be treated in our hospital. Our transplants, the bone marrow transplant, which is what we do as hematology oncology, has not stopped, has not changed. Patients with the blood cancers, leukemia or other diseases like this, need to be treated. Now, the question is, how is this possible when a patient with cancer is by definition a very immunocompromised patient because of chemotherapy, because of treatment? So these patients become the most vulnerable when we talk about COVID. So risk to take the risk of infecting a patient who has no immune defense and has also toxicity from the chemotherapy, from the cancer. So comorbidities, what we call the comorbidities, so the other diseases that can be problem with the kidney or problem with the liver or pneumonia or infection. These are the patients that have the highest risk of dying if they get infected. So we had to put in place a very defined strategy and separation of patients who could be at risk of COVID or with any symptom from the others. So limiting the access to spaces, immediately moving patients who could have been at risk out of the other patients, and especially testing every single patient for COVID. I think in our hospital, every single patient who is admitted to the hospital is tested, no matter what symptom or no symptom he has. But in particular, any patient who needs to receive chemotherapy needs to be tested, even if he has or she has no symptom, before starting the chemotherapy. So these are all procedures that, along with the social distancing, the universal masking, everybody having a mask, those are things that have become extremely important, especially for the patients that have the most vulnerable patients, like patients with cancer or patients with transplant that are immunocompromised the same. Two elements that I think are very hard, have been very hard for our patients. One has been that both in the clinic and in the hospitals, we have not allowed, unfortunately, to have any visitor or any family member with them. Not when they come for a visit, or nor when they are admitted to the hospital. Again, the mental component of cancer, of fear, becomes even bigger when someone has to live this event, cancer diagnosis or chemotherapy alone. It's very, very difficult. Patients have been expressing this. And unfortunately, the question is to balance the risk of having visitors and possibly exposing to infection, to COVID infection, other people, versus having the patient basically suffering alone. In some exceptions have been made, but I think it's nice to see in some way, and this has happened in Italy before, it's happened in all the other places, that these patients acquire a new family, which most of the times are the nurses. And these are the people they can talk to, they can relay their fear, they express, maybe they can call with the FaceTime their family from home and allow them to see their relatives and their children, their parents, there's whoever they want, their friends. This for cancer, a patient with cancer stay in the hospital for a long time. Often they can spend a month in the hospital. So there's a mental component, mental health component on top of the chemotherapy, on top of the fear, on top of the unknown outcome. And to this, there's also a financial struggle. We are seeing, and many of our patients, as many other people, are losing jobs because of the crisis. And this is basically putting them at risk of losing their insurance. And they need chemotherapy, and they need to be treated. And this is becoming an issue that we are facing as we speak. We don't have a solution. Our hospital has been extremely ready and capable of addressing these needs and supporting these patients financially. But this is going to be a second part of the crisis for the healthcare system that I don't think we know completely well yet. So what are we doing? What can we do to make the best of our options available to our patients? We definitely we have been increasing the testing to make sure that we don't have anybody at risk of having a COVID infection while having other procedures. We enhance and we emphasize over and over the policies that people should have at home with isolation in case of someone not feeling well, of using protection, or even masks, and washing their hands. We want to have follow the guidelines that the city of Chicago or the CDC has suggested. And then there's one more element that has become and is becoming, but has been already an important one and hard one as well. There are some ethical decisions that we have to make, the patient has to make. We have not talked about the age issue. We know that in Chicago at least, but probably all around the world, most of the people who die are patients above age 60, and actually even more if you go to age about 70. So patients who actually have multiple diseases, cancer, but also renal failure or other chronic diseases, if they happen to become COVID positive, they are asked, and their prognosis becomes very, very poor. So that's a struggle that we all face. And patients, if they happen to go to the intensive care units, it has to be a decision to what the patient wants and how much care, if the patient wants to be intubated, if the patient wants to be resuscitated, if the heart stops beating. And we try, our instinct, our mission, our vocation is to keep the patient alive as much as possible, because that's why we are physicians. But there are times where the patients tell you that they cannot take that anymore. With cancer, this can actually happen even more frequently, because these patients, at some point, especially if they've been struggling and fighting with the cancer for a long time and they're not young anymore, they see these things happening very quickly and become overwhelming. So there's an ethical component to our work that is challenging. It adds up to the burden that every physician has to carry from a knowledge, but also from a personal standpoint, which I want to emphasize because it's part of our life, our choice. But it's a component that right now is even more important. So the big question is, and there's a question that I also want to start asking to my colleagues is, okay, we have described what we do, what we can do. We are doing, all of us are doing surgery, dialysis, or any kind of surgeries. But we have, and we will have probably now, because this is not gonna stop. We hope to see less cases very quickly in the next month or so, but there will be still cases until the vaccine is available. What can we do when we have a COVID patient who needs surgery, or who needs chemotherapy, or who needs a dialysis or a transplant? How do we manage a COVID patient, of course not in the intensive care unit, with an acute need? These are open questions. We are, from my standpoint, from a chemotherapy standpoint, we have set up rooms in our clinic and in our hospitals to be able to treat patients with COVID infection with chemotherapy in a way that does not expose other people to risk of infection. First of all, the staff, the nursing, that have full protection equipment, but also other people there, and we also have to monitor these patients very, very closely to limit the risk, knowing that there is a risk for that. But I wonder what this is gonna happen for other patients too in every discipline. The last thing I want to, I think Dr. Gallon mentioned the fear that patients have to come to the hospital. I think one of the aspects that the fear has generated, one of the things that fear has generated is some patients, as he said before, did not want to come to the hospital, so they delayed their care. They preferred to not to tell what they were experiencing. They probably have ignored the symptoms, or they pretended they ignored the symptoms, not to make anybody aware because of the fear. Some of them, chronically ill, may have decided to surrender to the disease because they didn't see any hope in this thing and in this situation. And lastly, some of the patients, I'm sure they have panicked because of foreseeing the financial cost of co-payments in this time of going more to the hospitals because of possible risk of COVID and their diseases. So these are all factors that I think are important to be considered now going on, because these are not leaving the table, but we want to address them, all of them. So these are, I think, some of the topics. I'd like to see, and maybe I can ask first my colleagues to address what they think was going to happen with COVID patients in need of treatment. Enrico.
If you want to follow the same order, well, we were preparing to do a lot of cases on COVID positive patients. So that, of course, imply having special pathway, having enough of this PPE, personal protective equipment, and so forth. In 2 months, actually, we operated on a single patient COVID positive for an emergency. It didn't happen very frequently. They had also surgical emergency. 4 additional cases were found to be, while asymptomatic, to be COVID positive. And this is not happening anymore because now we have universal testing with the fast Abbott test. So we do no procedure without testing the patient before. So the main goal is to keep the operating room safe for everybody else. That is the overwhelming majority of people still not needing surgery. Surprisingly, we had very few patients COVID that required the operation. And by the way, we are perfectly prepared for that. In particular, there's some kind of surgery that really exposed the surgeon and the team to a very high risk, nasal surgery, base of the skull surgery. In this case, actually, we do with 2 consecutive negative tests before we agree to do the operation. So that's in the best interest of the patient as well as the healthcare providers. I've been surprised that we had so few, and I would be curious to hear the result in other hospitals. We do have a cooperative study sponsored American College of Surgeons that has already enrolled several thousand patients. And once this study is available, we'll know more about the general impact. But for our hospital, it's been surprisingly low.
Good, thank you.
Yeah, in urology, we had few cases. We operated on COVID positive patients. We had, for instance, a very advanced cancer in a younger patient. So we decided that was absolutely the case to operate this patient, and we were pretty well equipped. Now, doing this type of long surgeries under this this type of protection, it's a burden, and it's very challenging for the team as well. So we did it, and it went actually very well. I think that I've noticed that the indications for the surgery changed as the availability of the testing changed, and we went from being like a very challenging to patient on to have now clear guidelines for this. I have patients, it's interesting, opposite patients compared to what my colleagues were saying. I have patients that wanted to be operated because they say, I'm going to lose my insurance. I want to have the surgery done. And I remember one patient particularly challenging. She called my office and was threatening everybody and say, I know you guys are not doing anything. You are empty. Your ORs are empty. You have to operate me. And so that's you have to do like a small little reality check with these people saying, but have you opened the TV and listened to some news? Have you heard what is going on around here? So it's really not safe for you. So I think that the challenge is there also in the post-COVID. We have a tremendous backlog of patients. I by myself have more than 80 patients waiting to be operated in just 2 months of not doing much. So I think that we will have to find again the new strategies in doing this. So how we can implement this? When can we do? Maybe we can extend the time that we are doing. Or maybe we can also improve the performance that we are doing in the ORs. So these are my thoughts about this.
So, Lorenzo, do you have anything to add to the?
So I think at the end of the day, it's going to be for our patients, like you said, they're afraid to be treated. But at the end of the day, it's educations and apply the appropriate safety precautions. So for educations, let's face it, in the population that I take care of, patient on dialysis, if you are on dialysis, your mortality or your chance to be alive of 5 years about 50–60%. Now, if you get a kidney transplant, your mortality or your chance to be alive 20 years is probably 85%. So it's quite evident that transplantation is the way to go. Now, if you now look and compare patient on dialysis with COVID, a patient with kidney transplant with COVID, I told you before that if you are on dialysis, you get COVID, so far the data shows that your mortality is around 13%. If you are a kidney transplant, you get COVID, from the data that we have in our hand, is about maybe around 20%. So there is a little bit of a difference between the two, but I think it's quite evident that if you stay on dialysis and you had the risk of getting COVID, plus the fact that the on dialysis, your survival rate of 5 years is quite low, what you need to do, you need to get transplanted and take the risk today. So it's not even a question to me. In fact, there was an agreement with Enrico that many transplant centers in Italy didn't close the cadaveric kidney transplant program. They continue to proceed because they, obviously they knew that transplantation is not an elective service, it is a necessary surgery to get people off dialysis. Now, in regards to safety precaution, I mean, this goes without saying. You test patients, you test the donors, you test the recipients. You might want to procrastinate some surgery in COVID-positive patients, obviously. But I think as long as you apply the proper testing, I think this is something that our transplant center can do. I mean, we had to obviously adjust to this pandemic, but for the population that I care for, is quite intuitive that we need to start transplanting patients as soon as possible.
Okay, so one of the last things probably we want to discuss, I don't know how much time we have left, but I think there's a message we want to give to the people who are watching or listening. The risk is now, no matter how well we want to practice, we are still limited. We still have limited capacity in the OR, in the clinic, and so on the other hand, we want the patients to reach out to us. I think telemedicine is not just a way that helps some people. I think there's a risk of telemedicine, which is to privilege patients who have more resources. It may actually increase inequality because some of the patients who have no money or no resources may have more difficult ability to participate in a telehealth visit. And in that case, the phone should be probably the best way to reach out to these people. But I think also the risk is that many of these people, especially those who have less ability to contact through telemedicine, all of us may want to go to the emergency room more frequently. And this would become a bottleneck that will not help the patients probably, and also our institutions. The emergency room, but it's the only option that some people have. So maybe I'd like to have a comment on from all of you to how to what message, how do we ask our patients to be more aware and more enthusiastic about a new way to talk to us, to not to wait to be too sick and to go to the ED, as opposed to have see the phone call, the telephone call. Some patients do not like to pay for a visit that is done on the phone. It seems not like it is not the same, is not appropriate. And instead, this is a new way that actually will benefit them a lot, as opposed to going to the emergency room and not having the right treatment immediately because of too many people. So any comment on this from you? Enrico, you're muted.
A lot of telemedicine. No, I'm not. Doesn't show. Can you hear me?
Yeah.
Yeah, so we did a lot of telemedicine, and we were really worried about our patient population. We serve a lot of indigent population. We limit access to laptop, computer, and like. We have been very successful in using two different platforms to communicate with them. Those are platforms that allow us to communicate through smartphones that are very, very common even in low-income population. And we have been using mostly a Zoom upgrade from medical purpose and Doximity. With these two platforms, we have been really impressed on how receptive our patients have been. For example, we have a big operation in wound healing, And wound healing require as one of the critical steps to visualize the wound from our specialists. And with this upgrade of Zoom, and we have been able to really communicate well with them. The advantage is also that you can screen the patient, and if they need to come in for direct treatment, we can immediately communicate to them. I've been greatly impressed by telemedicine, and I agree with the previous speaker that is here to stay. For some application, I think we will substitute forever the direct interaction with the patient. And I think we just saw the beginning, already Medicare and other important component of healthcare are recognizing and paying for this form of service. And definitely agree with you that should be used as much as possible to avoid overcrowding of our emergency department.
Thank you. Yeah, it's important, I think. So, Director Luca, how much more time, or do you want to have? Do you have any questions, or do you have any?
Okay. Yes, actually, you have anticipated a few of my questions, so thank you for being such a perfect moderator. But yes, actually, I think you have all outlined the difficulties, the challenges, but also some opportunities in the emergency that we have faced. And as you were also mentioning, and many commentators are, we are going to live with COVID-19 for some time, hopefully not too long, but most likely, and being realistically, for some time. And as Professor Kocjancic was saying earlier, there are many patients, non-COVID patients, that haven't come to the hospitals and that will be crowding the hospitals in the upcoming months while we will still have a COVID situation going on. So during this time, you have developed strategies and outlined safety measures in order to face this amount of patients that will have sooner or later to come to the hospitals while a COVID situation is still going on. And the other question was if during this time you had contacts, or have you had any interaction with your Italian colleagues, and if let's say what happened in Italy and the fact that the emergency here exploded a few weeks later, let's say, gave us some advantage in terms of facing the emergency. Thank you.
Yes, we did. I think Alois will tell you that we probably were the first one in our institution to understand the burden that was coming. There was a comment, probably 2 to 3 weeks delay in the numbers that happened here, but we were hearing and reading and talking to our friends in Italy and hearing their cry and their screaming of especially the Lombardy area. And we were I was telling our colleagues here, we need, and there was a little bit of sense of not belief. No, yeah, that's Italy. It's not coming here. My division was probably among the first to stop patients from coming to clinic before anybody had started, because and it was only a matter of days and that happened. But my experience, probably everybody else will continue, that we were very much aware and in contact with our friends. I don't know about you guys.
Yeah, I would echo to what you just said, Damiano. So we were, of course, very connected with our peers and colleagues and friends from Italy, and we were listening to them. So when they're saying, guys, this is not a joke, so it's coming, it's real, and it's gonna change forever the way how you practice medicine, and it was true. So when we actually listened to them and we implemented the changes so that we were a little bit more prepared. For instance, compared to what just happened in New York. So it's probably a different patient population, but we have a very high number of patients, but we didn't see all this huge mortality as New York witnesses. So it's the connection with experts around the world is crucial. And this is what I really like in this. We start sharing this information. We have I'm pretty sure that each and every one of us is having like multiple meetings like this one tonight, a day, which we are sharing our experience, how we're doing it's going to probably change also the way how we are doing our scientific meetings in the future. So that's those are the lesson learned, and I think that we should probably keep a little bit more an eye on the public health medicine, not just onto super specialized medicine that we are doing. So just my take on this.
Well, I really took advantage of the contact with the Italian surgeon that have been actually keeping me informed throughout. And what we did, we actually shut down the active cases about 10 days before the proclamation of a disaster of the governor. And we eliminated the visit in the clinic except urgent one. What we did, we also acquired a lot of protective equipment for our doctor and nurse. And we were quite successful because by then nobody was buying. If you wait into the pandemics, it's impossible to find this N95 or similar. But we bought early and we bought in a large amount. So we've been able to protect our faculty and some other colleagues with advantage to have in our hands, without anybody rationing it, all the PPE that we need to do our job. And I'm glad to tell you that in my department and transplant program, we had virtually no cases of infection. So we benefit from the Italian experience, as painful as it was for everybody there.
Thank you.
Yeah, I would like to say also echo what was said by my colleagues, exactly the same. The connection with our Italian colleagues, specifically from Bergamo, allow me to communicate the level of emergency that existed over there. And even though there was a little bit of disbelief, denial here, I think it did help them at the end of the day to organize, submitting information to appropriate routes to actually prepare the hospital for what was coming to us. In fact, as a part of a group within the institutions, where we look at international relations with other universities, we actually start creating a network where information from other places, in case of future disasters such as this one or similar one, can actually be triaged appropriately to key decision makers within the hospital. So there's no delay on purchasing PPE. There's no delay on organizing the whole structure of the hospital to face something similar to this one. So I think again the Italians or the European were the one being hit first, but I think we had a little bit of time to organize. At least in Chicago, the wave of the virus when arrived to us, we have no even anything close to what happened to the East Coast. So I think this is because we were able to talk to our colleagues in Europe.
Well, then thank you very much for your contribution and your presentations. I appreciate in particular that, as I said earlier, you've outlined challenges, difficulties, but also a view and outline of what the future will be. And I think we have addressed all the different facets of this COVID situation for non-COVID patients from a medical point of view, the human point of view that was so touchingly addressed by Professor Rondelli, and the financial issues that this situation is raising. But above all, what I personally noticed, appreciated, is your the passion, the humanity, and the compassion that you have all expressed through your words beyond the medical technicalities. And so I think I can speak on behalf of all the attendees that are followed us on Zoom and on Facebook, that have felt this deep sense of humanity that you've all expressed. So thank you very much.
Thank you.
Thank you.
And I hope that we will meet soon in person again for some more scientific lectures and meetings at the Cultural Center.
Okay.
Thank you very much.
Thank you. Bye-bye.
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 Again.
Bye.
Bye.